Welcome to PGOG, Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is infertility, diagnosis and management of tubal factor infertility. We have already seen the initial assessment in a case of infertility. We have also seen the diagnosis as well as management of ovulatory dysfunctions, male infertility, and now we are coming to the next factor of infertility that is tubal factor infertility. Anatomy of fallopian tube. Length of the fallopian tube is 7 to 12 centimeters. We have four parts of the fallopian tube. One is the interstitial or intramural part. Then is the isthmus, which is the narrowest part comparatively as compared to ampulla, which is the wider part of the segment of the fallopian tube. And last is the femoral end, which we also called it as infundibular end of the fallopian tube. Now, this is the cross section, which is interesting to note here that for this intramural or interstitial portion, now this layer of the muscle wall is thick, whereas it becomes thinner and thinner as we progress from interstitial to isthmus and from isthmus to the ampullary portion where the wall is thinner. These multiple folds are mucosal folds. That means though it is a single lined epithelium, there are mucosal folds lining the inner wall of the fallopian tube, and these the cells which are lining these mucosal folds are tall columnar cells. We have total three types of cells. One is a basal cell, other is a ciliated cells, and third type is secretory cells. So these secretory cells are secreting the secretions into the inside the fallopian tube continuously. Ciliated cells are responsible for the ciliary action, which helps in the transport of sperms as well as fertilized ovum in the fallopian tube. This fallopian tube has the muscle layer, which is inner is circular and outer is longitudinal muscle. And this muscle contractions are leading to the peristalsis, normal peristalsis of the fallopian tube, which helps in the transport of the fertilized ovum. There is one especially of special importance or interest is there is a presence of a smooth muscle band, which is connecting the femoral end of fallopian tube with the ovary. So this is called as fimbria ovarica or ovarian fimbria, which is a smooth muscle band which attaches the femoral end of the fallopian tube with the ovary. There are certain risk factors for tubal factor of infertility, or when can we suspect that patient is having tubal factor infertility? Whenever there is a history of ectopic pregnancy, ruptured appendix, pelvic inflammatory disease, septic abortion, endometriosis, history suggestive of endometriosis or a diagnosed case of endometriosis, and any history of any prior pelvic surgery. All these are the risk factors for the occurrence of tubal factor of infertility. Now, tubal factor contributes in a major way for infertility. It is responsible for 30 to 40% of the cases of infertility as a cause of infertility. If there is no risk factor and if we do the chlamydia antibody test, and if chlamydia antibody test comes negative, then the possibility of having a tubal factor of infertility is less than 15%. So no risk factor, negative chlamydia antibody test, then we can say that the risk of having a tubal factor of infertility is less than 15%. It is not zero, but it is less than 15% will be the risk in that case. To diagnose tubal factor of infertility, the most important are hysterosalpingography and laparoscopy. HSG is the standard first line test. It is of importance whenever we are planning tubal surgery. In a suspected case of tubal infertility, factor infertility, we are planning to go ahead with the surgery, then the information which is provided by hysterosalpingography is of importance. 60% false positives we get with the hysterosalpingography with proximal tubal blockage. Now, proximal tubal block is block which is at the interstitial part of the or intramural part of the fallopian tube. Proximal tubal block is cornual block, in other words. So, if we get a cornual block on HSG, the possibility of having a false positive is 60%, so high. So what needs to be done is we have to repeat HSG in the next cycle, or we can proceed with the laparoscopy. Now, why there is a false positivity here is there is a um, as this procedure hysterosalpingography, we do it without anesthesia. There can be pain and there can be muscle spasm, uterine spasm can occur with whenever we are instilling the dye, and that uterine muscle spasm can lead to the false positive test of a corneal block on hysterosalpingography. Now, this HSG has got a therapeutic effect also. It is more, this therapeutic effect is more whenever there is a tubal flushing which is being done by oil based medium as compared to water based medium. So we have two contrast mediums which are available. One is oil based medium and other is a water based medium. If we compare these two, oil based medium is associated with greater therapeutic effect of the procedure itself. That means procedure itself relieves the minute tubal blocks by tubal flushing, and that is the reason oil based medium is preferred over water based medium. Laparoscopy is considered as gold standard test for tubal patency because we know that there are so many false positives with the HSG. Gold standard, if we are asked which is the gold standard test for tubal patency, your answer should be laparoscopy. Here also false positives are around 3%. That means there is no tubal block, but you feel that there is a block, and it is usually this misinterpretation of laparoscopy is because of the presence of dense adhesions. Most important concept for all of us to understand is these two tests are not exclusive of each other. That these are, on the other hand, they complement each other. That means whatever information we gain by HSG and whatever information we gain by laparoscopy are, the information is different, and in that way these two tests are complementing each other. HSG as well as laparoscopy both are done 2 to 5 days after cessation of menses. During menses it is not done, as it will lead to the difficulty in interpretation because of the presence of blood clots or blood. It is not done whenever there is a expected timing of ovulation and possibility of conception because of possibility of disturbing a pregnancy, and that is why the best time is to do it in the follicular phase only, and it is usually done from day 2 to day 5 after the complete cessation of menses. This is the correct timing. Prophylactic antibiotics are usually recommended because procedure itself can lead to the flaring of the pre-existing mild pelvic inflammatory disease. Doxycycline is the preferred drug which is given with a dose of 100 milligram 2 times a day for 5 days, and it can even be started 1 to 2 days before the uh, day of procedure. Non-steroidal anti-inflammatory drugs are usually given 30 minutes before the procedure, or even indomethacin per rectal tablet has also been shown to be effective in reducing the pain associated with procedure. Image intensification fluoroscopy is used. HSG cannula or balloon catheter is used to instill the contrast medium. This is HSG cannula which is inserted in cervical canal, and dye is pushed slowly. 3 to 10 ml of contrast is instilled slowly so that there should not be any spasm because of the pain if it is instilled too fast. Usually, three films are taken to reduce the radiation exposure. Oil-based contrast medium is preferred to that of water, as we have already seen in the last slide that therapeutic effect of oil-based medium is greater as compared to water-based as a tubal flush. Now here, this is how the picture comes in the uh, when we do hysterosalpingography, we need to do it in the radiology department under the supervision of a radiologist, where the facility for this high image intensification fluoroscopy should be available. And here there can be now here as we cannot visualize the tube at all, there is a possibility of either having a corneal block or spasm, and it will be an indication to repeat hysterosalpingography once again, or to proceed with laparoscopy. This is if collection is seen like that, then it is suggestive of a presence of a hydrosalpinx with a distal part of the fallopian tube being blocked. Laparoscopy is considered as definitive test for tubal patency. Chromotubation or chromoperturbation is done, and indigo carmine can be used or methylene blue can be used. Now remember that with methylene blue, rarely there can be acute methemoglobinemia, especially when patient has G6PD deficiency, and that is the reason indigo carmine is said to be safer as compared to methylene blue. It is instilled, and we can see the dye coming out of the femoral end, and this direct visualization confirms the presence of tubal patency, and that is why this laparoscopy is said to be a definitive test for tubal patency. In addition to that, what cannot be detected by HSG but by laparoscopy is we can visualize and detect the abnormalities like femoral agglutination. So femoria are agglutinated, or these are adherent to each other because of the presence of adhesions. Phimosis is femoral end is smaller than normal. Presence of peritubal adhesions also we can see by laparoscopy, which we cannot detect by hysterosalpingography, and these adhesions might be pulling the tube away from ovary. So this anatomical relationship between the femoral end and the ovary gets disturbed because of the presence of adhesions, which can be visualized when we do the laparoscopy. Endometriosis, we can see the endometriosis spots also, and that can also help us to diagnose endometriosis when we do the uh, laparoscopy. And endometriosis can add to the tubal factor by presence of peritubal adhesions. Laparoscopy can be another advantage of laparoscopy is it is diagnostic as well as in the same seating it can be therapeutic. That means we can do adhesiolysis, we can take care of endometriotic lesions. We can do the surgery for this femoral agglutination in the same seating. So it can be both diagnostic as well as therapeutic in the same setting, which is not so with hysterosalpingography. But with HSG, the most important advantage is we come to know the site of the block. That is the advantage of doing hysterosalpingography. Laparoscopy needs general anesthesia. It is expensive as compared to hysterosalpingography, and it might not be available at all the centers, and that might be the reason that at some centers for tubal factor of infertility we have to rely only on hysterosalpingography. Other tests for tubal factor assessment are sonohysterosalpingography, where with the ultrasonography HSG is done. Saline is instilled inside the uterine cavity and ultrasonography is done. Presence of fluid in pouch of Douglas indicates tubal patency, but disadvantage here is we cannot differentiate whether it is there is a unilateral block or whether there is a bilateral block. Now, especially if there is a presence of unilateral block, it can be missed because there will be presence of fluid in pouch of Douglas, in spite of having a block on one side only. It is so reliability is less with this sono HSG. Hysterosalpingo contrast sonography is another, which is called as high COSI hysterosalpingo contrast sonography. This is the results are comparable to hysterosalpingography, and advantages it can be done in the as outpatient. There is no need of any radiology setup, and it can be done by the gynecologist. Transvaginal hydrolaparoscopy has been tried. where the saline is instilled through the pouch of Douglas and the scope is introduced as we do for the coldoscopy from pouch of Douglas posterior fornix. But mainly we can visualize the posterior pelvic cavity. We cannot assess the anterior pelvic cavity is the disadvantage. Hysteroscopy flow technique, while doing hysteroscopy, indirectly we can comment about the tubal patency as we can visualize the entry of fluid or air bubbles which are passing through the um, interstitial part or the intramural part of the fallopian tube, which provides the indirect evidence. Chlamydia antibody test has limited clinical value because even if it is positive, it is not giving us the exact idea about whether there is a tubal pathology or not. Now, whenever we talk about this tubal factor of infertility, main clinical decision is there is only one question in the mind of gynecologist whenever we are assessing the tubal factor of infertility. Whenever there is a diagnosed tubal factor, whether to proceed with tubal reconstructive surgery such as minimally invasive surgery where we can do laparoscopic surgery, or a robotic surgery is now being tried nowadays, or whether we can proceed with a microsurgical technique, open technique with a microsurgery principles. Now, this tubal reconstructive surgery is less expensive, but it has a definite risk of ectopic pregnancy after the tubal reconstruction. Or whether to proceed with IVF, in vitro fertilization. With IVF, there is greater per cycle success rate as compared to tubal reconstructive surgery. It is less invasive IVF procedure as compared to this surgery, but it is more expensive. So factors which affect the decision, there are so many factors. Age of the woman, ovarian reserve, low ovarian reserve, elderly woman, we will go for IVF rather than going for a tubal reconstructive surgery. Site and extent of tubal pathology is most important factor. Other factors of infertility, invariably we have to proceed with IVF. Semen analysis report will give us the idea about presence or absence of male factor infertility. Experience of the surgeon will affect the outcome. Results of IVF of a particular center will also affect the outcome, and that is also one of the factor. Number of desired pregnancies by the patient, as multiple times she wants to conceive, it is better to proceed with the reconstructive surgery rather than IVF, because with IVF the procedure will be more expensive. Now, for the fallopian tube, we use the terminology as proximal tubal damage and distal tubal damage. Proximal is whenever there is a problem at the level of interstitial or intramural part of the fallopian tube or isthmus of the fallopian tube, whereas distal tubal damage is mainly affecting the ampulla or femoral end of the fallopian tube. So, proximal tubal damage, the report can come as on HSG, there can be a report as non-visualization of fallopian tubes. It can be because of the presence of a simple mucus plug, or some amorphous debris might be blocking the cornual end of the fallopian tube. There can be, as I said, there can be a spasm of the uterus. Uterine spasm will create a picture of a block, or there can be a true anatomic damage. Yeah, true anatomic pathology or some true anatomic damage because of some pathology. Anatomic proximal blockage can be because of these three reasons. One is salpingitis isthmica nodosa. Here, the isthmic part of the fallopian tube shows nodularity, and it can be secondary to bacterial infection, or pelvic inflammatory disease itself can lead to corneal block, or endometriosis also can lead to the presence of peritubal adhesions, and it can also lead to the block at the level of the proximal part of the fallopian tube. Whenever this proximal tubal damage is bilateral, it needs intervention. Unilateral, it doesn't need a major intervention. The intervention is in the form of tubal cannulation. So, proximal tubal damage, the procedure which is done is tubal cannulation. Tubal cannulation is done by using a coaxial catheter. Now, this cannulation can be done by two ways. One is by fluoroscopic guidance. By radiologist, it will be done under the fluoroscopic guidance, or it can be done while doing hysteroscopy with laparoscopic guidance. Whenever we are doing this cannulation, laparoscopy also simultaneously is being done to mainly to ensure that there is no false passage creation, or there is no perforation at the level, region in the region of the cornu. As we all know that a cornu has rich blood supply, there is anastomosis of uterine and ovarian vessels here. And if there is a damage here, sometimes there can be brisk hemorrhage also. And that is why this cannulation, the whenever cannula is being passed, the any resistance surgeon has to stop. So the threshold to stop because of the resistance has to be very low for a surgeon whenever he is attempting cannulation, either with the help of fluoroscopic guidance or hysteroscopically. Because if there is a perforation of the uterus, uterine perforation at the level of cornu, it can lead to the major intraperitoneal hemorrhage also. Failed cannulation is an indication to proceed with in vitro fertilization. Here, microsurgery is avoided. Excision of the blocked tube and then its re-implantation in the cornu, that is associated with very high risk of ectopic pregnancy, as well as there can be uterine perforation also, and success rate of this microsurgery is not good, and that is the reason whenever the cannulation fails, it is safer for a patient, or cannulation is not possible, or after a year of cannulation pregnancy fails to take place, it will be an indication to proceed with in vitro fertilization. Coming to distal tubal disease, it is divided in two parts. This distal tubal disease, one is called as one type of patients, it is called as good prognosis cases, and other type is called as bad prognosis cases. So, what is good prognosis cases is whenever there is though adhesions are there, adhesions are mild, flimsy adhesions are there. Tubal dilatation leading to hydrosalpinx is small. The dilatation is less, hydrosalpinx, size of hydrosalpinx is less than 3 centimeter in diameter. Walls of the hydrosalpinx are thin and pliable. And whenever we open this hydrosalpinx, lush endosalpinx is visualized when we do laparoscopically this procedure. We can even visualize the presence of mucosal folds, which is indicative of a good prognosis case. That means the chances of success and achieving a pregnancy are high whenever all these factors are present. Though adhesions are there, these are very fine adhesions. Tubal dilatation because of the tubal block is leading to a hydrosalpinx, which is small in size, less than 3 centimeters, with a thin wall, and lush endosalpinx with presence of mucosal folds. As you can see here, intact mucosal folds indicates that the damage to the inner wall of the tube, endosalpingeal damage, is less and chances of success are more. On the other hand, if these mucosal folds are absent and this tubal, the wall of the hydrosalpinx is thickened, that is associated with a bad prognosis for the success of this surgery. In with this good prognosis, now though we achieve a patency with this surgery in the good prognosis cases, whenever we do the tubal reconstructive surgery, still there can be a difference in tubal patency rate and pregnancy rate. And this difference is because of the deciliation of endosalpinx. As we have already seen, the inner wall of this fallopian tube inner lining is by the tall columnar cells, which are ciliated, and these ciliated cells are helping for the transport of fertilized ovum. So if ciliated cells are damaged because of the previous infection, that can be the reason that though the tube is patent, it will not be leading to successful pregnancy. So the surgery which is done for the good prognosis cases is either there can be what are the conditions, there can be small hydrosalpinx less than 3 centimeters, or there can be femoral phimosis. Phimosis is the opening, femoral opening is small, or there can be presence of peritubal adhesions. These are the three scenarios where we say it is a good prognosis case. A small hydrosalpinx with thin wall and lush endosalpingeal mucosa with the presence of mucosal folds. In that case, the surgery which is done is called as laparoscopic neosalpingostomy. This you need to remember, that surgery for a small hydrosalpinx where tubal damage is minimal is called as neosalpingostomy. So we are creating a new femoral end. That is why it is called as neosalpingostomy, which is laparoscopic surgery is preferred over the open surgery, as results are better with laparoscopic surgery. Laparoscopic neosalpingostomy for hydrosalpinx is done, as well as laparoscopically fimbrioplasty is done for phimosis. When the opening is smaller, then the fashioning of the femoral end is done, and then it is called as a fimbrioplasty, where if adhesions are there, adhesiolysis is done at the femoral end, and the fimbria are separated from each other, which are, if these are adherent to each other, these are separated. And with both these procedures, neosalpingostomy as well as fimbrioplasty, in the end, fimbria are everted either by taking sutures or with the help of the cautery. Fimbria are kept everted so that there should not be any recurrence of phimosis or recurrence of this block leading to hydrosalpinx. Fimbria are everted and sutured to the tubal serosa. Salpingostomy is done, and salpingostomy itself can lead to the pregnancy, and even if it fails to proceed with a conception or pregnancy, and if in future we do IVF success rate improves when salpingostomy is done. That is another advantage of doing these procedures for the distal tubal disease. Adhesiolysis will improve the ovum pickup. So these are the three procedures for distal tubal disease: laparoscopic neosalpingostomy, laparoscopic fimbrioplasty, and laparoscopic adhesiolysis. On the other hand, opposite will be the case with poor prognosis. Extensive dense peritubal adhesions will be present. Large hydrosalpinx will be visible, which will also be visible by ultrasonography, or clinically also we can palpate adnexal mass. This hydrosalpinx will have thick walls, and when we open this hydrosalpinx, absent mucosal folds will be seen. This endosalpingeal lining will be damaged, so that the mucosal folds will not be seen. That indicates that it is a poor prognosis case where the chances of pregnancy are poor in spite of doing a reconstructive surgery. In these cases, treatment is laparoscopic salpingectomy. Salpingectomy is necessary. It improves the IVF success rate. This is the most important concept of today's uh, point of discussion about the tubal factor infertility. Most important concept is, whenever there is a large hydrosalpinx, and in that case, if we do salpingectomy, it improves the IVF success by 50%. There is so much of reduction in success of the IVF if the hydrosalpinx is present. Why large hydrosalpinx reduces IVF success rate by 50%? There are some postulations which are given, theories which are given. Either it can lead to mechanical flushing of the embryos, or it can lead to reduced endometrial receptivity for implantation. And what is most accepted is there is a direct embryotoxic effect of the hydrosalpinx because of the release of toxic cytokines from this area of hydrosalpinx, which are entering into the uterine cavity and leading to embryo toxic action. And that is the reason why pregnancy rate is less, and if there is a persistence of hydrosalpinx. So when we remove it, or when we take care of this hydrosalpinx, IVF success rate improves by 50%. So it is important concept. Even if there is a unilateral hydrosalpinx, that also needs salpingectomy. Now, sometimes this salpingectomy can lead to spontaneous conception also. in some cases, IVF might not be necessary also. Salpingectomy does not reduce ovarian reserve is the new research which now there was so much of debate for many years that whenever we remove the fallopian tube, we are disturbing the ovarian blood supply, and whether it might lead to reduction in ovarian reserve was the main concern of for taking a decision of salpingectomy. But the recent data shows that salpingectomy is not reducing the ovarian reserve. This salpingectomy sometimes can be risky because of the presence of dense adhesion. That is the only problem, that even if we want to do salpingectomy, there can be intestinal adhesions, there can be anteriorly with the bladder, there can be adhesions, and that can lead to the danger or associated complications can occur because of these dense adhesions. That is the only pitfall of taking this decision of salpingectomy for a poor prognosis distal tubal damage with a large hydrosalpinx. So, what are the other alternatives to salpingectomy in a large hydrosalpinx if salpingectomy is not safe? What else we can do? So, we can do the proximal occlusion with the laparoscopy with wide fenestration of hydrosalpinx. Now, here proximally tube is occluded wherever it is possible. Wherever adhesions are less, proximally just occlusion of the tube laparoscopically also will take care of this ill effects of hydrosalpinx on the IVF. That is the idea. But why we need to give fenestrations over hydrosalpinx is there is a risk of increase in the size of hydrosalpinx with patient becoming symptomatic. So many times this hydrosalpinx is asymptomatic. But if we do the proximal this occlusion with the help of laparoscopy, there is a risk of having the increase in size and patient becoming symptomatic. Pain can be there. So if multiple incisions are given over the hydrosalpinx so that the secretion is draining into peritoneal cavity. Previously it was draining through the uterine cavity, and now here we are blocking it, and that is the reason fenestration is of the hydrosalpinx is recommended along with this proximal tubal obstruction. Second is we can do the aspiration of hydrosalpinx, especially USG guided aspiration of hydrosalpinx is done whenever in IVF cycle oocyte retrieval is being done. That has studies have shown that if it is done, that improves the IVF success rate, though the efficacy is less as compared to salpingectomy. Efficacy of the procedure, this aspiration is less. Chances of recurrence are high with the aspiration, but it is better than not treating hydrosalpinx at all. So if we compare this aspiration with no treatment as a control group, then the results are better with aspiration. But if we compare the aspiration with either proximal occlusion or with the salpingectomy, then the results are not that good. The results are less success rate of IVF, but because and even the chances of recurrence with aspiration are greater. Third intervention is sclerotherapy, where ethanol instillation is done in the hydrosalpinx, and this the results are better than aspiration. So if we compare, best results are or hysteroscopically, this assure device can be instilled, can be inserted, but it has shown that it is less effective in improving the IVF success. So if we compare all this procedure, salpingectomy is gold standard. Best is salpingectomy whenever there is a poor prognosis distal tubular disease with a large hydrosalpinx. But for some dense adhesions, and if it is not possible and it is not safe to do the salpingectomy, other alternatives, the next one which is effective is sclerotherapy, which improves the IVF success rate. Then we can go for proximal occlusion of the fallopian tube with fenestration of hydrosalpinx. These two are better. For salpingectomy is best. Better are sclerotherapy and proximal occlusion of the fallopian tube. Followed by that is the aspiration, and the least effective to improve the success rate of IVF will be assure assure is instillation by the this is the Assure is the this contraceptive device which is used, and we can insert it bilaterally if bilateral hydrosalpinx is present while doing the hysteroscopy. But its efficacy to improve the IVF is less as compared to all the other procedure. It is less effective. Aspiration is less effective. Assure is less effective. Better are proximal obstruction and this sclerotherapy, and best is this salpingectomy. Now, IVF is preferred over tubal surgery for the distal tubal damage whenever the woman age is more in elderly women. If there is a severe tubal damage is there, very large hydrosalpinx dense adhesions are present, associated male factor infertility will be will be a factor which will favor the decision for IVF over tubal surgery. And if there is a proximal as well as distal tubal disease, though the hydrosalpinx is smaller, but there is also proximal tubal disease in the form of a cornual block, anatomical block. These are the cases where IVF is preferred over tubal surgery. Whenever there is a large hydrosalpinx, again I am stressing salpingectomy is done, then it is followed by IVF. Always whenever we are considering this surgery for the tubal factor of infertility, preoperatively we have to take a consent for salpingostomy or salpingectomy as per the situation. Because when we do the laparoscopy, when we really assess the size of the hydrosalpinx, we see how the wall of the hydrosalpinx is, whether it is thin walled or thick walled. Then when we open it, we can see the presence or absence of intact mucosal lining. That will be the deciding factor which will help us to take a decision whether to proceed with a neosalpingostomy or whether to proceed with a salpingectomy. And that is why preoperative consent for salpingectomy or salpingostomy needs to be taken by doing a proper counseling of the patient, and that is most important preoperative preparation in the preoperative preparation for this tubal reconstructive surgery for a case of tubal factor infertility. Now, for sterilization reversal, so many patients, young women are undergoing tubal sterilization and then they do come for the tubal re-anastomosis. Sometimes there is some tragedy, loss of children or remarriage, and so many issues are there, and young women especially are coming for the with a request for tubal re-anastomosis. That is why it is also considered as one of the tubal factor where under the which is leading to infertility in these cases, tubal sterilization. Now this is one scenario where at present open surgery with microsurgery principles is considered gold standard over laparoscopy. Laparoscopically, the results can be achieved same as with microsurgery, provided the laparoscopic surgeon is experienced in that and highly skilled person. Otherwise, there is a challenge of fine suturing of the re-anastomosis after excision of this tubal sterilization site. So, procedure of choice is microsurgery with a open surgery. This is considered as gold standard for these cases. Robotic surgery is now being done, and textbooks are showing so many case series where the success of robotic surgery is as good as with open surgery. But robotic surgery might not be available at all places, and it is expensive, but the efficacy is same as with the open surgery with microsurgery principles. Some vaginal surgeons have tried to do the same tubal re-anastomosis by doing a vaginal approach, but it is less commonly used approach. So best is considered as open surgery with microsurgery principles. Now here also the prognosis is better whenever the tubal sterilization is done by using either ring or clip, as compared to whenever sterilization is done by ligation, resection, or by using a cautery. Then prognosis is better in young women. Prognosis is better if the final tubal length which is achieved at the end of the surgery is greater than 4 centimeters. And if it is ischemic re-anastomosis, then the success rate is more as compared to ampullary or cornual. The obvious reason is because the diameter is same, And that is why the approximation and re-anastomosis success is better whenever it is at in the region of isthmic part of the fallopian tube. Success rate is usually high, and the success rates are quoted as greater than 50%, from 50 to 60%. But ectopic pregnancy risk is 4 to 8%, which needs to be explained to the patient before taking a decision for re-anastomosis. Principles of microsurgery. Now, there are certain situations where we need to proceed with the microsurgery, and the procedure which gives us great satisfaction as open surgery is this tubal re-anastomosis, where if we follow the principles of microsurgery, success rate is high. So mini laparotomy is done, small incision is given. Operating microscope needs to be used for better results. Microsurgery instruments are available, small needle holder, small forceps, which goes in a long way in reducing the damage to the tissue. We need to have the gentle handling of the tissues. Minimum damage is to be done to the tissues. Suturing is done with the fine suture, 7-0, and even thinner than that. Methylene blue is used for to after once we excise this site of tubal sterilization, to confirm the patency of proximal end, methylene blue is instilled, so that when methylene blue emerges, we know that we have gone beyond the site of block. For distal end stabilization, stent is used, and usually a fine infant feeding tube can also be inserted through the femoral end for stabilization of distal end. First suture is usually taken at the mesenteric border, and there are total 4 sutures are taken: one at the inferior margin, one superior margin, one anterior surface, one posterior surface, and then followed by that serosal closure is done as a second layer. Now, throughout surgery, the for the clearing of the surgical field, mops are not to be used, as it leads to further damage. It can produce a factor of infertility by leading to recurrence of the adhesions or appearance of the adhesions, and that is why the surgical field is kept hydrated by continuously pouring saline over the surgical field, and with the suction, the removal of the uh, if there is any bleeding, then it is removed by using a suction, and saline is saline drip is used to keep the operating area wet. These are the important principles of microsurgery. If you are asked the principles of microsurgery for for tubal re-anastomosis, you should be mentioning all these principles. And more we adhere to these principles of microsurgery, better is our success rate of this tubal re-anastomosis procedure. To summarize, whenever there is a high risk factor for tubal factor of infertility, we need to diagnose the tubal factor by hysterosalpingography and laparoscopy. Combination of these two is usually used rather than sono HSG. At least I have not used this. What I have used is HSG and laparoscopy, and many centers are using the combination. These two are combined, and usually it suffices to diagnose a type and extent of the tubal factor of infertility. So if there is a tubal pathology, we divide it into proximal and distal tubal pathology. Proximal tubal pathology, the only procedure which we can proceed with is cannulation. If there is a small mucus block, or if there is a minute adhesion present at the level of the interstitial opening, then cannulation usually is successful. Any resistance to cannulation, the procedure needs to be abandoned, and we have to then proceed with IVF rather than going for corrective surgery. So there is no role of corrective surgery for a proximal tubal block is most important concept. Whereas distal tubal block, we divide it into good prognosis and bad prognosis cases. Good prognosis cases are where the adhesions are flimsy. If there is a hydrosalpinx, it is a small hydrosalpinx with a size less than 3 centimeters. Walls of hydrosalpinx are thin, and good tubal mucosa is present with presence of mucosal folds also. It can be visualized. In such a case, there is a prognosis of reconstructive surgery is good. Or if there can be femoral agglutination or phimosis. All these are good prognosis cases, where for adhesions we do adhesiolysis. Small hydrosalpinx procedure is done as called as neosalpingostomy. For all these procedures, laparoscopy is preferred over laparotomy. For femoral agglutination or phimosis, femorioplasty is the procedure of choice. At the end of both these procedures, femoral eversion is done to prevent recurrence. Bad prognosis is dense adhesions with a large hydrosalpinx. In that case, salpingectomy is done followed by IVF. It is, as we have already seen, that large hydrosalpinx will be mainly releasing the toxic cytokines which we have embryotoxic action. Or if salpingectomy is not feasible because of the dense adhesions, we can do the laparoscopic proximal closure of the fallopian tube along with the fenestration of hydrosalpinx, and then we can proceed with IVF. Or we can do the sclerotherapy by instilling ethanol in the hydrosalpinx, and then we can proceed with IVF. Or this aspiration can be tried along with the ovum retrieval with UHG guidance, or Assure can be introduced hysteroscopically, but both these procedures have less efficacy to improve the IVF success as compared to the other procedures. If there is a tubal sterilization reversal which is necessary, then in that case, open surgery with the principles of microsurgery gives us the best results. Robotic surgery also is giving the comparable results, but with laparoscopy, the results are not very good unless the laparoscopic surgeon is highly skilled to do it. Thank you so much. Now, this is the important reference. I have prepared the whole topic by taking help from this American Society of Reproductive Medicine, role of tubal surgery in the era of assistive reproductive technology, a committee opinion 2021. Then from Spirops Gynecological Endocrinology 2019, and I have also taken help of T-Lens Operative Gynecology 2019. Thank you so much.